Welcome to the Neural Implant Podcast, where we talk with the people behind the current events and breakthroughs in brain implants in an understandable way, helping bring together various fields involved in neuroprosthetics. Here is your host, Ladan.
Welcome to another Toronto Rehab Week 2019 Spotlight interview presented by IFAS, the International Functional Electrical Stimulation Society. Thanks to them for sponsoring these episodes. Do you want to introduce yourself?
I'm Vivian Mushahwar. I'm a professor at the University of Alberta. I'm in the Department of Medicine, which has multiple divisions, and my division is the Division of Physical Medicine and Rehabilitation. My background is in electrical engineering as an undergrad, bioengineering as a PhD. Then I did 2 postdoctoral fellowships, one in rehab medicine, because I really wanted to be able to understand what the clinical reality is like, and the other is in neuroscience. So basically, I bring the engineering all the way with the rehabilitation with the neuroscience together on a daily basis for the purpose of developing interventions that would improve function after neural injuries or diseases. So my passion has always been, how can I make a difference? And I started off doing engineering because I just loved physics and math, and I continue to love physics and math. Yeah, strange. But towards the end of my undergrad, I was disillusioned as to what do I really want to do with my life, because I couldn't really see myself in the back of a lab somewhere building computers for the rest of my life. I really needed that human interaction. And at the same time, I'm Palestinian in origin, so I had gone to Palestine to visit my family. That was during the first uprising, and I saw a lot of kids in wheelchairs. And that's usually not something that you see. They were injured because of the unrest and what have you. So all of a sudden, I really wanted to do something about this. And that's how I got very much into walking, standing, walking, and restoring mobility the best as possible. So that gave me a beautiful new direction, and I found the field of bioengineering. It was relatively new on books. I mean, people have been doing biomedical and bioengineering for years and years and years, but it wasn't a program at universities.
Maybe they were calling it something different too.
Yeah, exactly. So I discovered this field and discovered my passion, and all of a sudden there was a really nice matching of interests. And I just really fell in love with bioengineering. And I started off for my graduate program, which is a project that I proposed. It really came as from an engineer who didn't know their biology at that time, where I just wanted to reconnect the spinal cord, right? So what's the problem? There's cable above, cable below, just reconnect. Yeah, it doesn't work like that.
It's a little bit more complicated than that.
It's a little bit more complicated than that. But still, that kind of continued to be my passion. So as a PhD, I tried to investigate what the spinal cord has in terms of networks. How can you activate them? Could you really activate the spinal cord itself to restore mobility and what have you? And then I went to Emory University to do my first postdoc, where I want to work with people with spinal cord injury who also had spasticity. So I wanted to now be introduced to the reality. Right? I want to restore walking, but what are the other issues that have to be addressed?
What's the issue with spasticity? Why is that dangerous?
Well, it's uncontrolled contractions, is to put it in a simple way, right? So if you're trying to produce a movement, will this uncontrolled contraction become a problem? We don't know. In fact, it seems like with electrical stimulation, you would reduce those uncontrolled contractions, but I didn't know that at that time. And it was still early on when we're trying to understand how electrical stimulation interacts with these different physiological mechanisms. But I wanted to understand spasticity. How do you work with it? How do you control it? How do you improve it? And I got very interested in a process called operant conditioning that my lab at Emory University was working on, where you just basically give biofeedback. So you stretch somebody's arm. If they have spasticity, they end up with this huge response. If they're neurologically intact, usually you don't end up with that response. So now you can train them through biofeedback. You show them this huge response and say, do whatever you need to do to reduce it. So that was something that I was very interested in. How do you now start inducing plasticity in the nervous system through these techniques? So it was an additional area. I didn't use electrical stimulation there, but I learned how you can start inducing plasticity in the nervous system, because you can induce plasticity through electrical stimulation, but there are other methods that you could do that as well.
So it kind of sounds like the opposite of approach of what you were originally doing. Like, instead of coming in, I'm going to come fix this, I'm going to take one side and the other and put them together. You're like, actually, I'm not going to do that. I'm just going to help the body speed up that process by
I'm going to help the body speed up. Well, I realized I need to learn more about the body.
Yeah.
So I can't just approach it as an engineer because it's not a robot. And its responses are unpredictable and what have you. So so it was very necessary for me to learn the neurophysiology and the neuroanatomy and the neuroscience. And that's when I realized that, taking two cables and connecting them is foolish, right? However, it also taught me where you can get signals, how can you now control, so you can still stimulate below the level of an injury in the spinal cord, so you still activate those networks. What are those networks? How do they receive control? If I understand how they normally receive control, can I use that same mechanism to now activate them, right? So I learned more about the neuroscience and the neurophysiology and the reality of spinal cord injury, and how can you now start stimulating when you need to, use training type of approaches to shape it differently. And I think all of these techniques have to come together to give you the best outcome.
Okay.
That's really how it is. At least that's what I believe, and I think a lot of people believe so as well.
So what are some recent projects then, I guess? I mean, this was a little bit
off. And then, but then I also realized that I needed to learn more neuroscience, and that's why I went to the University of Alberta to learn even more in-depth neuroscience, to get more about this plasticity, how can you shape it and what have you. But, my passion still was, let's get people out of their wheelchairs and walking again. Stimulating in the spinal cord was something that showed great potential. So that was a project that started in my lab and continues to this day. So the idea is you put very, very fine implants inside the spinal cord. So not just at the surface of the spinal cord, actually inside the spinal cord and below a level of injury. Activate those networks that we now know a whole lot more about from years of studying and produce standing and walking. Now, we haven't really translated this to humans yet, but we're in the process of doing that. And what we found out is that with this stimulation method, using biologically controlled signals, you can get your subject to walk more than 1 kilometer. Can you even think about that? I mean, this is unheard of. Well, obviously with exoskeletons now, you could wear them, but they will walk for you. But this is now you activating, we're activating the spinal cord, and the spinal cord is activating the muscles in a meaningful fashion that we produce this standing and walking movements. So that's something that's going. It's an invasive project, so it takes a long way to go. But during this whole work that we've done with spinal cord injury and people with spinal cord injury, pressure ulcers were just staring us in the face. I never thought that I would be working with pressure ulcers, but they were just there. And I started reading up on them because obviously they get in the way. We need to get people standing, and there's this pressure ulcer. So I started researching what pressure ulcers are all about, and in fact came up with the idea of SmartyPants, even though it wasn't called SmartyPants, when I was still finishing as a graduate student, and just sat on it and kind of...
Long enough to cause a pressure sore, a bed sore, you sat on this idea?
No, but I, as a neurologically intact person, actually use the same principle as SmartyPants. So SmartyPants does what I do. And that's why I don't end up with a pressure ulcer, because I shift my posture. I fidget all the time, even though I sit in front of my computer for 8 hours, sitting on SmartyPants. But the bottom line is that the concept of SmartyPants was so foreign to people. It was just ridiculous. I mean, once you understand the science of what causes a pressure ulcer, once you understand the science of anything, the solution becomes a little bit more obvious.
Yeah.
So we understood that what causes those nasty pressure ulcers is not just occlusion of blood vessels, which is what everyone in the clinical world is taught. It's actually more mechanical deformation of the muscle. And that muscle can start breaking down within 10 minutes. And it's deep. It's that deep bone muscle interface. You don't see it. And it just grows and grows and grows, that damage, until it starts showing up on the skin. Well, by that time, it's too late, because clinically, that's how you notice, that's how you detect pressure ulcer or pressure injury, by inspecting the surface of the skin.
So is it muscle also affected in terms of like oxygenation, like blood flow and everything like this, or is it something, or is it mechanical?
That's a secondary pathway.
Okay, that's
the first pathway is this mechanical deformation. The moment you sit on your tissue, you do this, you're deforming your tissue.
Yeah.
Skin is fine being deformed because it's facing the elements. It's fine, right? And fat is kind of loosey-goosey. It could shift. But muscle has a structure, and it's not designed to be deformed. It's designed to shorten, but not to be mechanically deformed. And it takes about 10 minutes from deforming a muscle cell for it to start dying. Okay? So if you sit and you really stop yourself from moving, like you have to focus on it, because you move unconsciously, you will be in pain, because your muscle will actually be starting to tell you, I'm starting to break down, right? But we usually shift our posture a whole lot sooner than before you get this signaling. So we realized that what's out there from a clinical perspective is not really the first pathway. So the mechanical deformation is the first pathway. Now you stop the blood. Of course, when you sit on things, you reduce the oxygen. That makes things even worse. So the damage that's induced by the mechanical deformation is actually even exaggerated when you add lack of oxygen to it. So really, SmartyPants came from that. Now we understood that mechanical factor, and then we said, fine, if there's a mechanical factor, and it's not just oxygen, why is it that I can sit in front of my computer writing a grant and not develop a pressure ulcer? And that's when we watched people very carefully, and they shift. They shift their posture every 6 to 9 minutes, and you do it in your sleep, right? So you just constantly fidgeting. Obviously, fidgeting doesn't have, it could have a clinical connotation, but really, you're constantly moving around, even though you're in your seat.
You should have called it like fidget pants or ants in my pants.
We actually did call it ants in your pants because the wireless communication in it was the ANT protocol, ANT protocol. So we actually did call it ants in your pants, but it wasn't going to fly.
So basically, what I understand, it's like a TENS unit that is maybe woven into fabric, into pants, and it causes you to fidget, kind of just randomly shocks you every 6 minutes.
So it does a contraction. It holds the contraction for about 5 to 10 seconds, and then it releases for 10 minutes.
Okay.
And then it does it again. Why 10 minutes? Because 6 to 9 minutes But the very important thing is that you want the system to work 24 hours a day. So you can't be stimulating too frequently or more than you need to, because the muscle will fatigue. And then it's that muscle contraction that's really important to prevent those pressure ulcers from developing. So you need a
pajama version of this too.
You need a pajama version of it. So it's an underwear right now. It could be regular underwear that is modified, or it could be a special underwear. But we've got multiple prototypes that fit anyone and everyone. But for people who have incontinence, they're not wearing regular underwear, so we use an incontinent product, SmartyPants, which is disposable. People in the intensive care units, they don't get in any garments. You just put the stimulating patches on their skin, and that works just as well. So that's really the concept of SmartyPants, and we've tried it in all sorts of models, obviously from animal models, but certainly a whole lot of human volunteers with neurologically intact, with complete spinal cord injury, with MS, with stroke, with all sorts of, or bone and joint conditions that stop them from moving. And it was across the whole spectrum, only one person didn't want SmartyPants.
Oh, really?
So really the acceptability, because we asked for acceptability, in addition to safety and feasibility, and one person didn't want SmartyPants. What they thought, they just didn't want to deal with it. But everyone else wanted to take the system with them.
How many people is that?
So we had more than 100 people.
Oh, wow. Okay.
More than 100 people.
So,
and some people wouldn't give it back because our research protocol would say you gotta give it back, and they wouldn't,
I lost
because they would use it. So a couple of people use it continuously for 18 months when we weren't supposed to do that. And what they found out is that in addition to obviously strengthening their muscles, so there's a positive other benefits, other than not developing a pressure ulcer, stronger muscles, it actually managed their pain. So they were on pain medication because of their spinal cord injury. They were able to reduce the dosage substantially because of SmartyPants.
Wow.
So it had all these unanticipated benefits that we weren't really quantifying.
Yeah, I believe it. Like if the muscles are getting some kind of input, then they're used, and then that
and the health of the muscle,
the health of the muscle, the health of the nerve,
exactly.
It's much better. And then there's less noise. The body can filter it out or something like this. So what's the state of SmartyPants right now? You were saying something like it wasn't.
I wasn't as mature as I should be in terms of commercialization. That was the first, innovation that we were going to commercialize.
Okay.
So there were 2 patents that I not very intelligently signed away to a startup company. Well, it was a subsidiary of another company, and that company had reasonable record in terms of commercializing electrical stimulation devices. So we thought, well, they've got we kind of know them. They've got the record. Why not just assign it to them? So they created a subsidiary, and the challenge was that we assigned the majority of the intellectual property to them up front, and took it out of the university, put it into the startup, and it just didn't move the way we thought. And somehow the contract was done that there wasn't adequate recourse to get it back. So it stalled.
How long has it been?
It stalled. It's been stalled for about 4 years.
Oh, wow.
Yeah, it's unfortunate. But every single SmartyPants that's out there was developed in the lab, and we have everything. We have the sewing machines, yet we have the whole thing. We developed the simulators ourselves. So everything was developed in the lab, which could be very easily transferred to another company that may be more capable, who could take that technology. The challenge is that I'm not the majority holder.
So what's the prognosis? Do you think it'll get better, or is it just going to continue to be stalled?
Well, a lot of even charities are starting to make noise about this, right? Why is it stalled? They either have contributed funds to it, or they have their constituents want it, right? So why is it stalled? And my strategy was, I really don't have a majority voice, so you have to approach the company. And they're starting to apply pressure. So hopefully the company would be willing to just release the intellectual property and allow others to do it. I mean, forget about making millions of dollars. I think that the company was just so sold on wanting to make millions of dollars that they really lost sight of what needs to be done.
But I mean, sitting on it doesn't financially benefit them,
not.
right? So,
and it doesn't benefit anyone who's going to take it, because the patents have been issued, and they're just losing,
time on the patent.
On the patent, losing money.
Wow.
Yeah.
Well,
but
that's
the thing is, but we've got. I mean, anyone who takes it up, we're more than willing to give them everything, because we're doing this to put it out so that people can benefit from it, and we'll give them everything that we have in terms of knowledge and know-how. I mean, there are a lot of tricks to making the pants so that it doesn't cause a pressure ulcer.
Yeah.
Right? So you can't just put any pants and think that they're going to be safe. But we're happy to work with anyone who takes the technology and moves it forward.
That's really cool. You've done this so maybe other people can learn, like, hey, this is something you have to watch out for, or have some kind of recourse, as you said, if they don't do it in a certain amount of time, or, whatever, just be really
careful. Just be a little bit more intelligent. So
trust
with
but verify, maybe.
Yeah, exactly. It was all that trust and basically almost a handshake, really, where it was. But this second thing, that the SOC, SOCC, so it's smart. Of course, everything has to have smart in it, but it's smart ongoing circulatory compressions. That's what that is, and that's for the lower leg to activate the gastroc and the tibialis anterior to prevent deep vein thrombosis, and not just prevent deep vein thrombosis from forming over here, but forming over here as well. Because
so on the calves and
we
on
only
the
put it here, but our system
audio,
is
so
adequate.
We have to describe what we're doing.
So our SOC activates the gastrocnemius and the tibialis anterior muscles below the knee, and what we're finding out is that that's more than adequate to mobilize the blood, not just in the below the knee, but above the knee and up to the heart. So we think that we have a very innocuous yet and attractive, yet very functional system for preventing the formation of deep vein thrombosis. What we're finding out, in addition to that, is that deep vein thrombosis develop for multiple reasons, but one of them is stasis. So in other words, there's not a whole lot of movement, and so the blood pools, it clots, and then if the clot leaves the leg, goes to the lung, that's almost sudden death, right? Or it would cause long-term lung issues for the person, right? So that's why deep vein thrombosis is very critical to prevent in people with reduced mobility. But in smokers and even pregnant women are at risk of deep vein thrombosis. People who are undergoing cancer treatments. There's a whole slew of people who travel all the time, airline travel. So there's a whole slew of people who would be at risk of deep vein thrombosis. This is the idea that it would work. But ultimately, we'd like to put it in hospitals, because that's where the vast majority of deep vein thrombosis form. In fact, if you're in a hospital as a patient, you're 100 times more at risk of developing a deep vein thrombosis than if you were out in the community. So eventually, our goal is to go. We're still working on them. So the idea is to move it to the patient population as soon as possible, but also make it available as a consumer product for others.
Cool. So you'll make Smarty stockings then.
We make Smarty stockings. But going back to mobility, I don't know if you saw one of the posters, but we also are with our extensive knowledge of neuroscience, having gone through all this training, I became very curious as to why people don't exercise the whole spinal cord when they're trying to restore mobility, when they're trying to restore walking. So I'm not quite sure if you've noticed one of the posters, but we advocate the use of simultaneous arm and leg cycling as a means for improving walking after a spinal cord injury. And we were, again, ahead of our time, and people were just saying that what we're doing wasn't going to work, because cycling supposedly doesn't transfer to walking. If you want walking, you train walking, right? That's how rehabilitation goes. So we demonstrated that actually cycling does translate to walking. And if you add the arms synchronously with the legs, you double the improvements in walking in people with incomplete spinal cord injury, double them relative to all other gait-specific interventions. So that's very exciting. This is a system that we developed very early on, kind of a cut and paste. And that was before we started patenting things. So it's not patented. Nonetheless, we're very excited about the fact that there are systems out there now that allow you to do arm and leg cycling, because this could be a very effective rehabilitation intervention, not only for walking, which we look very carefully into, but for cardiovascular function, for fitness, right, for all sorts of benefits. So that's something that probably is not commercializable because there are other companies out there doing that. But what we are working on is translating the protocol to different clinical centers and having them use that. And interestingly, one of the charities in Edmonton is putting the arm and leg cycling devices at the YMCA out in the community. So they're more and more accessible to people who could leave rehabilitation and then continue to rehab themselves. It's more like rehabilitation at your doorsteps, if you want to think of it that way, where those devices are available in your community, right? So you can go and exercise and continue the benefits. Yeah.
Wow.
So wide range of projects.
Yeah, wide range of stuff, but it's really cool. It's really
Yeah.
promising. I mean, it's simple, it's simple, but it's not easy, right?
Yeah,
but
exactly.
it could be very, very helpful too.
But the thing is, again, our concept is what is the simplest way to get to X? So there's obviously the engineering hat, but there's also the neuroscience hat and the rehab hat. And what we're finding out is that by engaging all these hats, not just me, but the different communities, and of course the users themselves, we're finding out that we're coming up with simpler and simpler. The solution's not always simple, but there are some solutions that are simple. Once you understand what the pathology really is, you are able to come up with a simple solution. And we're hoping that these would be, effective in people's lives. The idea is that they need to be able to use it and not have it as a hassle. If it's a hassle, don't bother, right? So you need it to be as easy as, getting up out of bed and just getting on with your life. And that has to be just part of that. Yeah.
That's awesome. That's really
Yeah.
great. Any final words, any parting thoughts?
Well, I like what you guys do. This is absolutely fabulous. So, obviously at this conference, a lot of people are aware of electrical stimulation and what have you, but it's not something that the full clinical world understands or appreciates. There's still this notion that technology, especially if a functional electrical stimulation technology, be it implantable or not, certainly even if it's surface, there's this hesitation in North America particularly. And I think it's absolutely necessary through efforts like yours, to start changing this concept. And I'm not quite sure how wide is your reach, but certainly the wider, the better. So that's one way to do it. But I think there has to be, and maybe you guys can help with this, there's got to be a fundamental change in how clinicians are trained, be they doctors, rehab, like physiatrists, or physiotherapists, or occupational therapists. There's got to be a change in how they're being trained. Yeah.
Okay, cool.
Yeah.
Hope you enjoyed the show and were able to learn something new, bringing together different fields in novel ways. Until next time on the Neural Implant Podcast.